So let's just talk about, you just want to go work your shifts and come home. Fair enough. There's nothing wrong with that. Being an ER doctor is very noble, and that is sufficient. But I'd say one thing you can do at the bedside is be aware of and challenge your own biases. I think that's one of the first steps that people can do. That's why I advise the governor that implicit bias training would be something that would be a tangible action we could all work on for every provider in the state. And, I'll say, I have my own anecdotal experiences. For example, in medical school, where I'd be in rounds and I'd hear my attendings talk about how they didn't know if someone was really unhealthy, or they couldn't tell if someone had a rash because they had darker skin, or having an African-American patient whose hair was falling out and saying, oh, well, I think that's normal because they're African-American, so their hair should be falling out. I've had interactions where it was during the month of Ramadan, and a woman had come in with abdominal pain, and I literally had a nurse tell me, oh, well, it's Ramadan, so we don't really have to worry about it. I'm not going to check her vitals. She's just fasting, so we should send her home. There's nothing to do. Well, why would we not treat someone? Why can we not identify a rash? Why can we not identify that it's unhealthy for someone's hair to fall out, or that someone could be having cholecystitis? We really have to think about and check our biases and our assumptions about the people that we're treating. And again, it's just human nature. When people are not like us, or we perceive them to be not unlike us, then our biases absolutely do factor into how we think about their care. And that can have an impact on us being able to diagnose. It can have an impact on quite frankly, our attitude when we're interacting with a patient, and how that patient perceives the healthcare system. If someone comes in and they think they're being disrespected, or they're not being listened to, or they're being disregarded, they're less likely to want to engage in care. They're more likely to leave against medical advice. And so those are all the things that we just have to be mindful of as practicing clinicians. Another important thing is to just assess your patient's social determinant of health kind of needs. And I'd say that you're not kind of anointed with a social determinant. We all have social determinants of health. Those are the things that determine how likely you are to be healthy. So it's not something that someone's kind of pinned with. They're just things. If someone can't get to their doctor's appointment, if they just lost their job, or they just lost their insurance, you may not be able to fix the system. I'm not asking anyone to be a social worker in the emergency department if you're the physician, but can you at least ask the question and ask, do they need any help with getting somewhere? And don't make assumptions. Don't make assumptions, quite frankly, if someone is a person of color, that they're poor. I think that's important as well. Don't assume that if someone is white, that they don't have access issues. We really have to see the patient in front of us and at least ask the question. I would say another thing, and my residents who work with me, I feel like they're always laughing because I always bring public health into my shift. But you got to be at least a little familiar with some of the local resources that are available to your patients. I know I often, because I would be in the health department kind of running programs there, I would sometimes just bring some flyers in. Bring some flyers into the emergency department and just say, hey, there's a clinic over there on the corner. You don't need to come back to the ED for this particular thing. You can actually go to a clinic, or there's resources here. Those are just very simple things that can be done. If you're in a leadership medical director role in an emergency department, you can do that too. Keep those resources updated. Don't necessarily wait till someone's homeless or they have a placement issue to do any type of social needs assessment. And I'm not asking for a robust assessment and filling out a form. It's just like, hey, you just lost your job here. So you can at least ask the question, give them a flyer, and just try a little bit as you're discharging them. And I'd also say, know your emergency department's referral programs and use them. I was just working in the emergency department this past weekend, and one of my patients was positive for COVID. They weren't that sick. And I said, oh, well, what about, can we connect them to monoclonal antibodies as an outpatient? The resident said, oh, I forgot about that. Oh yeah, I guess maybe we could. I get that in the flow of patient care, sometimes it can be challenging, but at least know what exists in your emergency department, but also in the community. So if you have more broad emergency department kind of operational authority, there's also things you can do. That's that second column there. You can promote diversity in hiring. You can promote mentorship and promotions to really increase the diversity of who's working in your emergency department or in your hospital. It's pretty well established that when you have a diverse workforce, when your patients see themselves in the people who are treating them, that you tend to have improved outcomes and better experiences when it comes to engaging with the healthcare system. Now, don't get me wrong, that does not mean that you need to be African American to provide high quality, unbiased care to someone. Absolutely not. But it does help to have improved diversity in your emergency department. And I'm a big fan of maximizing public health interventions in the emergency department. I used to wave this flag before the COVID pandemic. And I think that now we all really understand you cannot separate public health and public health crises from an emergency department. And it actually benefits us and us being able to actually execute and practice and keep our emergency departments functioning when we pay attention to what's going on in the emergency department. So whether it's hepatitis A, testing and vaccination, something I pushed when I was Detroit's health director, and we were in the middle of the largest hepatitis A outbreak in modern history, whether it's flu vaccinations, COVID vaccines. I know that it can be challenging, and it's something new. It's something that has to be thought out when it comes to operations. I totally recognize it's a challenge when you got 50 people in the waiting room, but let's just be honest, when people are waiting around for a long time, there are often ways that we can integrate very simple, I'll call them simple, obviously I'm biased, public health interventions that can actually have an impact in the broader community if we just kind of take some time to think them through. I'd also say when you're looking at your metrics for your emergency department operations, take a little more time and look at your metrics and at least try to break them down across race and ethnicity. If you're not measuring it, if you're not identifying it, you're never going to be able to fix it. So I would challenge people as you're working on your QI projects to actually look at your data and try to see if there are any disparities that you may even be exacerbating by your projects. In the community, it's really important. I think that hospitals and communities should be connected. I think it's a shame that many hospitals had no idea who their local public health officer was until the pandemic hit. Well, you probably knew me when I was in Detroit because I was just a busybody and knocking on everyone's door. But oftentimes people don't know who their local government officials are. And that's really a loss. It's really unfortunate because those relationships are really critical. Oftentimes local health departments don't have staff, but they do have certain authority, and they do have the ability to partner with you to actually be able to advance some of the work that you may want to do in your emergency department. I'd also say from a research perspective, implement community-based participatory research wherever you can. And so this is just very simply engaging with community members. You don't have to have a PhD or master's degree to be able to participate in research. Don't just go research in a community and not really engage them in the entire research process, designing a study, being an author in the study, engaging the community as far as the results and what should be done next to actually address whatever the finding was. That real spirit of CDPR is really important. I think would go a long way. And then also, finally, this is where I've spent a lot of my past, I guess, 7 years or so, but advocate for policies that best serve your patients. You know more than anybody what your patients are experiencing and what you see in the emergency department. Serve on important committees that drive policy and programming. And I'm not going to be doing this, but people can certainly run for office, because what's better than having ER docs be in charge?